Okay, hello and welcome, members of the Chinese Medicine Practitioner Meetup Group, hosted by Kamwo. My name is Thomas Leon. I'm the organizer of this group and your host for this afternoon or evening, depending where you're logging in from. I just want to take a moment to welcome new members to our group. I hope you enjoy what we have for you tonight, and hopefully many more events in the future. The mission of our meetup group is to connect members with respected authorities on subject matters within our profession. The events are always free, and our speaker suggestions come from you, the members. So if you have a suggestion for speakers, send them to us. And currently this is our 135th event, meetup event. So that's quite a good number of them. But I think this is only our maybe 15th that are over Zoom exclusively. So although I know there's some people email me and said that they really like to have the in-person meetups. At some point we can get that started again, but you know, the upside of doing it on Zoom is you get amazing reach with people from all over the country. So it's definitely a plus. Anyway, by attending tonight, each of you will receive a $20 coupon via email. So please look for the email that will be forthcoming in the next couple of days. So look in your spam box if you don't see it. So here are the ground rules. Please mute your microphones. But I would feel free if you, feel free. And I would even encourage you to leave the camera on, as past surveys indicate it is a moral boost to see other faces within our community, you know, when we're sharing the space. That's one of the things that came back on the survey. People just miss each other and they want to see, you know, it's true, it's great. But if you're shy, you can always turn your camera off, that's fine. It's not being recorded, your face is not being recorded, but other attendees can see you as well. So there will be a Q&A session at the end, so please hold off questions unless it is something directly relevant and very urgent. You can always type it in the text box and I will get the speaker's attention. So tonight's talk will be about 1.5 hours. It will go up until 8 o'clock Eastern Standard Time. And so it should be wrapped up about, 8 o'clock. So anyway, allow me to introduce tonight's speaker, Pony Chiang. I know Pony from Pacific College, and all I can tell you is that he's brilliant when I met him, and he's even more brilliant now. So let me introduce him. Pony Chiang received a PhD in biomedical research from the Institute of Medical Science, University of Toronto, followed by a master's degree in traditional Oriental medicine from Pacific College of Health Sciences in New York. He's an adjunct professor and founder of the Integrative Acupuncture Certificate Program for the Faculty of Health at York University in Toronto. Pony is also a professor at the American Neuro Acupuncture Institute in Santa Fe, New Mexico. He's a leading expert in peripheral neuroanatomy of acupoints and their associated neuromodulation needle techniques. Pony has been invited to lecture at various international TCM and biomedical acupuncture symposiums and to conduct workshops in North and South America, Europe, and also Australia. Dr. Chiang is a primary author revising the fundamentals of Chinese medicine, the one that we all use in school, which is feature original dissections and illustrations for over 400 distinct acupoints. So if you all can give Pony an applause, I think on the internet, I think we do this, right?
Thank you.
So, very welcome to Dr. Chiang. Thank you.
Okay, so I need to share my slides now. Okay. First of all, I'd like to thank Kamwo and also thank Tom Leung, who I prefer to call Professor Leung because he was my herb teacher, herb 3. many, many moons ago. It's a tremendous pleasure for me to reconnect with the New York community. That's where I consider my TCM home. That's where I did my Chinese medicine training, and certainly even did internships in the Grand Meridian Clinic at the Kamwo with Dr. Roger Tsao. So this is it's a treat for me, and it's kind of a walk down memory lane. So I really cherish this opportunity. Thank you, Tom. Today, I'd like to share with you a recent publication of mine, and which concern obviously the facial nerve. My contact information is on the first slide here. Feel free to connect with me and stay in touch, or just share some clinical, if some of the information I share with you tonight, you found it very useful for your patients and you want to, ask a question or just share your success stories, I'd love to hear from you. I'm starting off with the picture of a classic text called the Zhenzhou Jiayi Jing, which is translated in English as a systematic class of acumoxibustion. This book was published in the 3rd century by the author shown on the right side here, Dr. Huang Fumi. Now, everybody knows about the Ling Shu and the Su Wen as being the oldest Chinese medicine text, but I like to think that the Zhenzhou Jiayi Jing, or the systematic class, doesn't get the respect that it deserves. It is actually considered among scholars of Chinese medicine as the first complete acupuncture manual. Wait a minute, don't you, isn't Ling Shu and Su Wen supposed to be, an acupuncture manual as well? Well, it is, to the extent that the 160 points are taught in those combined manuals. But what about the rest of the points? As you know, there are now at least 360, or if you count extra points, 400 plus points. Where the rest of those points come from? The rest of those points were actually first taught or mentioned in the systematic classic, and it's for that reason is considered the first complete acupuncture manual. And it's a manual because it's meant to be useful for practitioners, not just theory, which is a lot of what Ling Shu and Su Wen is about. So what makes it a manual is that it actually tells you very detailed point location, how to needle it, how long to retain the needle for, and even if you were to use moxibustion, how many cones of moxa you're supposed to use. So it's very, very instructional based. So what I did when I started my research is first I needed to respect this tradition, and but unfortunately, this text did not survive on its own. It's thought to be lost. Okay, and but from historical records, we do know of a volume, okay, called the Yellow Emperor's 3-volume systematic canon of acumoxibustion, and it is known that this volume is comprised of 3 texts, hence the name 3 volumes. There's the Ling Shu, there's the Su Wen, and there is another book called The Bright Hall Cavity of Acumoxibustion. And so it is this Bright Hall book that actually did not actually survive. And it is through the Zhenzhou Jiayi Jing that we even know about its existence. So the assumption is that the information that's in the Zhenzhou Jiayi Jing that differs from the Ling Shu and from the Su Wen would then have to be, by deduction, coming from this Bright Hall manual. So systematic class is important in a way because it is a synthesis of all 3 of these books, and one of which is now lost. And the importance of the Zhenzhou Jiayi Jing, okay, is that, as I mentioned, it has the location of additional 189 points that were not mentioned in the combined Yellow Emperor text. So together, up until the time of the 3rd century, there were 349 points, making it up to that point in time the most complete acupuncture manual. And what I've done is I've translated the location of these 349 points from the original classical Chinese, and then went on to analyze their point location in juxtaposition of modern neuroanatomy. So I needed to review scientific published papers. Whenever there was gaps in the literature and couldn't answer the question I needed to, then I ended up having to learn to dissect myself, and had to apply for ethical approval to photo document these dissections. And so, but that wasn't enough, because just because you demonstrate a point is associated with certain structure or certain nerve, it doesn't mean it's something that we can actually successfully stimulate with our needle. So taking it from the level of the cadaver to the level of a real life human volunteer or patient, we then went on to do electrical stimulation of these nerves or these structures that we found that are associated with these points. And if this structure is a sensory nerves are known to distribute certain areas. For example, everybody knows the median nerve goes to the lateral 3.5 fingers. If the point located of a median nerve and you stimulate that point, that your volunteer will be able to tell you where they feel the dirty sensation, and that's how we can confirm that we can actually stimulate this point. In contrast, if the point is related to a motor nerve or a motor point, then you electrically stimulate that, electricity will flow down that motor nerve into corresponding muscles and cause muscle contraction. So it's something that we can visualize and we can confirm. So this is done systematically over many number of patients, over volunteers, over many number of years, so that the information I present to you is highly consistent and highly reproducible. And then we want to be able to demonstrate that this is not something just me, Pony Chiang, can do, that we can teach this to other clinicians and they can obtain the same dirty sensation, which with the anatomy or neuroanatomical structures, whether sensory and motor nerves or sometimes autonomic nerves that I've decoded. And then, but this serves a larger altruistic motive, is that by standardizing these targets, we can improve inter-practitioner reproducibility. So my associate, my clinic, can predict ahead of time what's the dirty sensation they're supposed to get when you get this point, so that I have peace of mind knowing that if I was away to teach a workshop and my associate steps in for me to treat my patient, they were going to get the same exact result because we have agreed on it beforehand. What is the dirty sensation specific to that point? And then finally, in terms of elevating the acceptance of our profession, when you have standardization of the targets that you're stimulating, then when you have research papers published by different research groups, then you can then confidently say, yes, my stomach 36 that I'm stimulating is the same stomach 36 as you're stimulating, because unfortunately at this moment in time, our profession or our research is not taken very seriously because oftentimes it's not reproducible. And how can it be reproducible if your dirty sensation is not reproducible to begin with? So this is sort of like my larger motivation behind why I'm doing this research. So I hope that gives you a little bit of background where I started. So this work included all the primary points of the body, and of course, including points on the face, which is why you're here today. We're gonna now shift gears and just talk about the points on the face that pertain to facial nerve trunk and facial nerve branches. This information was recently accepted by the Medical Acupuncture Journal. It's the Journal of the American Medical Acupuncture Association. And I would just like to take this moment to acknowledge my co-author, Mariana Martins, who is a duly licensed medical doctor and the registered acupuncturist. And the title of this paper is Anatomical Specificity Between Acupoints and Facial Nerve, a cadaveric study. This pretty little diagram summarizes the information I'm about to present to you in the next hour. What you can see is the ramification or the arborization of the facial nerve, and there are different names of these branches. And just quickly look at this for a second and appreciate that every single branch has points on its path, including the branch in which the nerve emerges behind the earlobe, which, as we all know, is Sanjiao 17. So this nice little tree diagram over here explains to us where the nerve exits the foramen from the brain, its different divisions, there's different branches, and very beautifully, there's a point for each one of these branches. This is the sort of spoiler alert of my research. Ancient masters passed on these points to us because they were very careful and wanted us to know that acupuncture points is a map to stimulate the peripheral nervous system. I understand that might be hard to accept by some people, and I understand that this is I'm only able to show you the information about the face. So it's okay if you have a hard time trying to understand or accept the East and West differences in the meridians and the nervous system. All I can tell you is that once I've done this research, I started to see this strong relationship between acupuncture points and peripheral nervous system. It didn't make me lose, the mysticism of acupuncture. If anything, it made me even more passionate about acupuncture because it allows me to understand what the real intent of acupuncture is. And if their intention is to pass on the mat to stimulate the peripheral nervous system, then it's okay for me to study neuroanatomy and neuroscience and neurology because it's only going to make me a better acupuncturist. Let's start by doing a little quick review, just in case it's been a while since you look at the neuroanatomy of the face. This diagram here, it shows you the branches of the facial nerve, cranial nerve 7, it is also known as. And there are a few main branches. There's the temporal branch, which innervates the temporal, emerges in temporal region, so it's easy to remember. There's a zygomatic branch. Imagine the zygomatic bone is over here, so the branch that goes to the zygoma, and actually innervates the orbicularis oculi muscle. There's a branch that's called the buccal branch, so it goes to the cheek region and innervates some of these cheek muscles. There's a branch called the mandibular branch. In the literature, sometimes they'll call this the marginal mandibular branch, just to avoid confusion with the mandibular division of the trigeminal nerve, which is cranial nerve 5 or V3, so that there's absolutely no confusion between cranial nerve 5 and cranial nerve 7. Sometimes they use the term marginal mandibular branch to separate the idea that it's a different mandibular branch. Finally, there's a branch that goes to the neck, which innervates the platysma muscle. That branch is called the cervical branch. But a lot of people don't realize that the facial nerve is not just innervating the face. Notice that there's a branch behind the ear that's not completely shown. That's called the posterior auricular branch. So it innervates, it goes backwards, and it actually innervates the occipitalis muscles as well. So the facial nerve is pretty interesting. It innervates the frontalis in the front, but also innervates the occipitalis in the back. So in totality, it's innervating most of the muscles on the face and scalp, with the exception of the muscles of mastication, like temporalis muscle, masseter, the pterygoids. Those come from the trigeminal nerve. But with those little exceptions, the majority of the muscles that's above your neck all come from the facial nerve. This next slide here is a nice little picture to help you review the musculature of the face. As I continue with my lecture today, I will be mentioning a lot of these muscles. So it's a good place to come back and refer. I just mentioned a couple of them that I will be referring to. Frontalis muscle is responsible for elevating the eyebrow. This orbicularis oculi muscle here is responsible for closing the eyes tight, shut. It's important to remember that opening the eyes has nothing to do with the facial nerve. Opening or cranial nerve 7, opening the eyelid is actually cranial nerve 3, oculomotor nerve. Facial nerve is only responsible for closing the eyes. Then you have muscles over here, zygomatic and buccinator. These muscles, what they do is that they allow you to smile and show your beautiful teeth, okay? And so what they do is that they innervate these muscles on the cheek here, but they also innervate the orbicularis oris muscle. So another orbicular muscle, or circular muscle. And so they involve responsible for lip movement. Then there's muscles that are more in the chin area, over down here. So if you kind of shrivel up your chin or your palate, your lips, you're engaging these muscles down here. These are called the depressor muscles. Okay, and then finally, what's not shown here is there's a platysma muscle, a thin layer of muscle over your neck, the most superficial layer of muscle in your neck. That's called the platysma muscle. This is a cool little picture that shows you the different facial expressions that can result from specific activation of individual muscles. So I'll leave that here as a useful reference for everybody. I like to just draw your attention to the last one here, platysma. So the platysma muscle is how it kind of quote unquote pops out the veins in your neck like that, kind of like a cringy look. You know, when you make a dad joke, your kids go cringy. That's the platysma muscle. Okay, so that is also innervated by the facial nerve. The last branch was called the cervical branch. This diagram here shows you some of the important arteries and vessels in the face region. And I only have that here because some of the traditional point locations, and what do I mean by traditional point locations? Aren't all acupuncture points traditional? Well, unfortunately, Chinese medicine reveres, or fortunately or unfortunately, reveres older texts. So that's why Ling Shu is considered more relevant, let's say in the text from the Ming and Qing dynasty, for example. So the point location I'm sharing with you comes from the systematic classic. So it is oftentimes different and actually may have more detail than the point location that's been passed down from Ming and Qing dynasty, which are the sources that TCM, or the modern integrated medicine form of Chinese medicine, since formation in People's Republic of China, those standardized course materials draw mostly from point location with the Ming and Qing dynasty, and this is why it may be a little bit different and surprise you. The point location and the landmarks and that sort of thing that's given in the systematic classic. So we're now going to show you a series of videos so you can appreciate what is the proper Doqi sensation and what's the proper activation of specific acupuncture points as they stimulate different individual branches of the facial nerve. So here you're about to see a device called a pointer pulse device. Just in case you're not familiar with this device delivers a 10 hertz of monopolar stimulation. It's just a 9-volt battery device. And when I depress the button, it sends a current to the tip of the pen. So whenever I touch the tip of the pen to the needle, electricity is conducted into the needle and into the muscle or nerves that the needle is adjacent to. So as we all know, this location here is Taiyang location. So same old regular location as modern location. That point location hasn't changed. And it corresponds to the temporal branch of the facial nerve. So if you were to refer back to the slides earlier, the temporal branch innervates the frontalis muscle. So its activation will be able to raise the eyebrow. Okay. So notice the angle of needling is towards the posterior direction. And that is because the nerve runs in this direction. So we want to needle perpendicular to the path of the nerve, transversely, which will increase our success of intersecting that nerve. You could certainly needle perpendicular to the skin, but you might not be so lucky. You might land here, land here, land here, land here, right? But if you know the nerve is running this direction where my cursor is showing, by intersecting its path, you increase your odds of interacting with that nerve. Okay. Next, we're going to talk about gallbladder 3. Okay, so gallbladder 3, as is being passed down from the systematic classic, these locations are translation of systematic classic. It tells us that this point is located on the upper surface of the top of the raised bone in front of the ear. So this is the reason. There's a reason why I purposely keep the original. I don't tell you that it's that is the zygomatic bone that is sort of the raised bone in front of the ear. I want the reader to be able to make their own inferences, right? If as a translator tell you it's a zygomatic bone, then if the translator makes a mistake, then the reader who doesn't read Chinese is forced to accept that mistake, right? But by leaving the door option open for those who have sufficient interest, can they analyze these texts and decide for themselves where that point should be, okay, and therefore what structure they may or may not be stimulating. This point is located in the hole formed when the mouth is open, and this is what I mean. This is a complete acupuncture manual. It tells you how deep to needle, how long to retain it for 7 breaths, how many moxas to use, and so on and so forth. Okay, so this picture here on the right side here is not my dissection. It's a paper published as indicated over here. And these surgeons were interested in finding out the path of the zygomatic branch of the facial nerve. And they have a quick little trick, which I want to share with you. All you have to do is find the tragus of the ear, find the lateral canthus of the eye, make a line between the two, and then from approximately 2.5 centimeters from the tragus, that location is going to be a good place for you to start going in and searching for the zygomatic branch of the facial nerve. Why is the zygomatic branch of the facial nerve important? It innervates orbicularis oculi muscle, which closes the eyes. So imagine you have a patient with Bell's palsy. They have to tape their eyes shut when they sleep at night because they lost the function to close that branch, right? So this is the reason why we learn the anatomy and learn the Dirty sensation and confirmation. So depending on what patient present, they may not present with dysfunction of all the branches. Maybe it's been a year and some branches has improved and just the lip branch is not working or just the eye closing branch is not working. So why do more than you have to? You want to be specific, only target the relevant dysfunction. So notice, again, the needling direction here. That paper tells us that approximately you connect the tragus to the lateral canthus, right? That's your line. And my needle is transversely perpendicular to that path, okay? So now don't worry so much if this is not exactly textbook point location of gallbladder 3, okay? For me, gallbladder 3 is whatever achieved the correct Dirty sensation. This nerve starts all the way down here, right? And it starts branching towards orbicularis oculi. There are many places along that nerve that will still give me the Dirty sensation. For me, an acupuncture point, of course, has to agree with the classical location. But once you understand what that location is meant to stimulate, there's no need to be super dogmatic. It's actually, you can be dogmatic and say, oh, exactly whatever swing from here and there. But if you're not getting a Dirty sensation, then there's no point, right? No pun intended. So it's the Dirty sensation that defines the point. It's not the two-dimensional location, right? So I hope I don't get questions about, oh, it doesn't look like gallbladder 3. I want to make that clear. So here you go. Let's watch. You get very clear closing of the eyes, okay? And you can attribute that to the orbicularis oculi muscle. Next, we have a little bit more information from that classic. I'm about to talk to you about small intestine 18. Okay, now small intestine 18, okay, is a point that if you look at the modern point functions, by modern I mean Alice and Wiseman, The Fundamental Chinese Acupuncture. That's the book I'm revising from Paradigm. If you look at Deadman's Manual of Acupuncture, these books talk about small intestine 18 being able to treat twitching of the eyelid. Okay, so, and if you look at the original source of the channel theory, which is from chapter 10 of Ingstru, it tells us that the small intestine channel has a branch that separates on the cheek and arrives at the nose and reaches the inner eye corner. And it is based on these texts. The Ingstru and Sun didn't have pictures. It's just ancient Chinese characters, classical Chinese characters. And but it's based on these characters that scholars imagine and deduce the channel theory. And it's based on this idea that it reaches the nose and goes to the inner corner of the eyes, that we then learn in school channel theory that there's this ... line that goes towards the inner canthus of the eye. This is all part of the small intestine channel signal. It's small intestine channel. What I have found from my research is that every time these ... lines are described, is actually a very detailed branch of the peripheral nervous system. It's very, very exciting to be able to decode this. And I made that discovery by accident one day when I was doing cosmetic acupuncture. Later on in this presentation tonight, I'll share with you a couple of techniques I use to improve facial muscle tone and symmetry. So go well beyond just treating wrinkles. You can do more for your patient than just treating wrinkles. You can make the smile more symmetrical. Our standard of beauty in all different cultures is symmetry. So if you can improve, the movement of the eyebrows, improve the movement of the lips so that it looks symmetrical, then that's considered more attractive in most cultures. So I want you to look at this picture, this video I'm about to show you, and you're going to see that there's movement. You're going to see movement around of the lips, right? So that's because this branch of the facial and buccal branch innervates the cheeks and upper lips. But I want you to also take a look at the lower part of the eyebrow here, the medial part of the eyebrow. Do you see a little bit of subtle depression of the eyebrow going down here? Okay. So when I was doing this on my cosmetic acupuncture patient, I saw this out of my peripheral vision, and that kind of weirded me out a little bit because I didn't expect the buccal branch to affect the eyes, right? The buccal branch is supposed to, according to the literature, affect the cheek. That's the name of the point, buccal. But thankfully, I paid attention in Chinese medicine class, okay? And I remember that there's this branch, channel theory. So I knew I was activating that branch that's going towards the inner canthus of the eye. That's therefore responsible for this movement. I just needed to be patient until a paper came out in 2006 that was looking at the innervation of a muscle called the procerus muscle. Procerus muscle is this muscle over here, kind of in the in-tongue region. So for the longest time, anatomists thought that the procerus muscle was innervated by the temporal branch, the one that innervates the frontalis muscle. But what they were surprised to find was that based on this dissection they've done, tiny little branch here that follows up here towards procerus, PM stands for procerus muscle, and this is just an artistic rendition, this diagram below, that is actually the buccal branch that moves the lips. For some reason, has a branch that goes to procerus muscle. Therefore, confirming that thousands of years of channel theory is in fact based on hard neuroanatomy. It's the discoveries like this that keeps me up at night, and inability to explain things that also keep me up at night. So this little dissection I want to share with you, showing you that facial nerve trunk approaches this area. And so it becomes, this is what's called the buccal branch. It innervates some of these muscles for smiling, it's called research muscles or zygomaticus muscles. But then we have a little bit of branch here that is starting to make its way towards the procerus area. So this is a video of the buccal branch for you, and see if you can see a little movement of the depression of the medial eyebrow in this lady here. So you will use this branch, small intestine 18, at the same location, lateral canthus of the eye under the zygomatic bone, and but the needling is underneath the bones, and what you're trying to do is stimulate the buccal branch of the nerve, which will activate all the cheek muscle and all the upper lip muscles. The next branch, as we go down, it's called the marginal mandibular branch. Remember I mentioned that in order to avoid confusion with the mandibular division, which is the trigeminal nerve, V3, they call it marginal mandibular, okay? So this one here is kind of interesting, and it's different than modern point location. It tells us that stomach 5 is also called a marrow opening. It's located 1, 2, and 3 feet in front of the crook of the curve of the chin. So the crook is most likely the angle of the mandible. But it also mentions something called a pulsation here. And that's something that modern point location doesn't mention when it comes to locating stomach 5, okay? And so what is this pulsation? This pulsation here is actually the facial artery, which is being colored in for you in this dissection that we've done. And we see a lot of examples where the text gives you clues about pulsation. Pulses are easier to feel than nerves, but a lot of times pulses travel together with nerve as a neurovascular bundle. So if you can feel the pulsation, then the nerve is just right adjacent to it. Or in a very interesting situation here, you see a case where the pulse intersects the nerve. So by palpating the pulse, it also brings you very close to the nerve. So for some reason, which we don't know and we can only speculate, a lot of these important landmark of palpatory information for point location that's around in the systematic classic did not survive into the Ming and Chiang, and therefore did not survive into the modern TCM textbook. And that's unfortunate, because had they survived, I think we would have made the appreciation sooner that peripheral or acupuncture points are anatomical, and that they are a detailed map to stimulate the peripheral nervous system. So let's take a look at the stimulation of this. Notice the angle again. If the nerve is running across in this direction, then we want to be perpendicular to its path when we needle. All right, so now watch the activation of the lower lip and also the chin muscles. These are the mentalis muscles and the depressor muscles, okay? And then lastly, at the level of the angle of the mandible, which is small intestine 17, that's a location we can stimulate the cervical branch of the facial nerve. And in here, you activate the platysma muscle, the one that pops up the veins in the neck. So you can see the vibration in the neck. And you notice that the corner of the lip is being pulled down a little bit. That's because the platysma actually is a thin membrane that crosses over into the jawline. So it will actually tug on the jawline. Some people like to treat the platysma for improving sagging of the chin. There are different techniques will do that. Here's another technique I offer you. Rather than needing the platysma itself, which you have to put many needles because platysma is not very big, why not just stimulate the nerve to the platysma, and with one needle, you can activate and tighten and firm the entire platysma with one needle. This is the power of understanding anatomy, okay? we need to talk about an extra point, what's located in front of the ear. It's called qianzhen. Okay, and qianzhen means literally means pulling upright. So it hints at the idea that they knew this function of this point is to rectify asymmetry of the face or face drooping when you have facial Bell's palsy. This point is located at, depending on the source, 0.5 or 1 anterior to the auricular earlobe. So in this picture here, earlobe is over here. Where the circle is shown will be where you can stimulate the facial nerve. So what would be this location? How will make this position different than all the other branches I talked about earlier? The other points I mentioned only specifically target one of these branches. Those are called branches. The qianzhen point is a trunk before their nerves have arborized or ramified. So qianzhen in a way is more powerful if you succeed at needling it, because with one needle, you can potentially activate multiple branches of the facial nerve. Okay, so once again, just to show you, these points are passed down for a very specific neuroanatomical purpose. These points are not just random points. Okay, they are, in my opinion, amazing anatomical records. So this point can be needled in two different ways. You can needle from top down or bottom up. And because the electricity will find its way at the tip of the needle, you can expect that if you were needling top down, you're more likely to affect the branches that are the lower on the face. If you're needling bottom up, you're more likely to affect, let's say, the temporal branches, those zygomatic branches that are higher in the face. So here's a video showing you just one of those two stimulation, and see for yourself what's being activated. You're seeing the eyelids being activated, contracting. You'll see that there's a little bit of frowning of the eyebrow over here as well. So the temporalis branch that innervates the frontalis muscle is also engaged. So the electricity is only going up to the higher branches of the facial nerve. Now, what's even more powerful than the qianzhen point is the granddaddy of facial acupuncture points, and that's from Sanjiao 17. Sanjiao 17 is the foramen from which the facial nerve emerges from the brainstem into the head, the neck, and then it will make its path into the face. And don't forget, there's a branch to the back as well. So what qianzhen cannot do is qianzhen cannot affect the branches to the occipitalis muscle in the back, right? But because Sanjiao 17 is located prior to this division, interior and posterior divisions, it will be able to encapsulate everything. Okay, so watch this. You'll see now with one needle, we have complete activation. We have raising of the eyebrows, closing of the eyes. We have some flaring of the nostrils, moving the cheeks. We're moving the chin, and see if you can see moving the neck, the platysma. That's coming from the cervical branch. So that is all 5 branches. Now take a look at the back. See how the ear is being pulled back? You'll see that it's actually activating. See the backward movement there? So it's activating the occipitalis muscle in the back as well. So therefore activating both the anterior and the posterior divisions. So if you do one point for a patient with Bell's palsy, this would be the most important point. But you gotta needle it right, because if you needle it and you don't actually get the facial activations, then you're just stimulating some of the muscles or superficial nerves in this region. You're not really doing what that point is supposed to do, which is to help all the individual branches. So the point of pulse device becomes a very useful confirmational tool. It tells you, did I do my job well, so that this patient who's coming here to see me for Bell's palsy is really going to get the result that they're paying for you for. Okay? Otherwise, if you put a needle in that area and you think you're getting facial nerve, if you didn't confirm it, very high likeliness that you actually have not affected facial nerve. Now, I'm going to wrap up the neuroanatomy portion, then we're going to go talk about strategies. Okay, so what are some of the remaining points that are related to facial nerve that I have not talked about? The remaining points I have yet to talk about pertain to the points that are right on the edge of the ear. We talked about Sanjiao 17 just now, right? Which is the granddaddy point. But there are a lot more points in the Sanjiao meridian. There are points that are Sanjiao 18, 19, 20, 22 that are all around that ear area. I was very happy to finally be able to decode this. It turns out that Sanjiao 18 specifically targets the posterior division, and that's known in the literature as posterior auricular division. because it's behind the ear. So it goes on to innervate the occipitalis muscle, but it also innervates some of these tiny little muscles. And these are called auricular muscles. And so what they do, even though the ear is not shown here, what they do is actually move the ear. Like, you have a dog, or you go to a farm, you see horses and cows, they can move their ear to swat the flies that's irritating them, right? They have the ability to move their ears independently and in any direction they want. Humans have lost the ability to do that. Some of us can still do it, okay? I have yet to meet anybody that can isolate all three of them, like move it up and forward and back, okay? And but so if you're one of those people, message me, I'll take a video of you, okay? And but what it turns out is that these points that are around the ear specifically target individual branches to these muscles. In other words, Sanjiao 20 is the nerve called the superior auricular nerve to the superior auricular muscle. Sanjiao 22 is the anterior auricular nerve to the anterior auricular muscle, so on and so forth. Even though this is not something that's super clinically useful. Now, a patient might come to you and say, oh, I got twitching my eye, twitching my lips. Very rarely will somebody say to you, hey, doc, I can move my ear the other day, but now I cannot move my ear suddenly, right? That's not exactly the type of thing that's going to build your practice. But having said that, I have had a couple of patients that came to me with spasms in this muscle. And so it's quite irritating because the ear is always moving, okay? So enough that they can notice, and a bystander can look at it and see that. So that then affects their sleep, and obviously gets them more all grumpy and depressed. So it can have a much more powerful effect than you think. So knowing that we have these points that's been passed down for that purpose, and next time if you ever had the opportunity of seeing somebody who has weird spasms of the face, now you have an idea how you may be able to help these people. And that's the reason why these points have been passed down. So let's take a look at stimulation of Sanjiao 18, the posterior auricular division. So you're going to see movement of the ear, but you also notice the movement of the hair in the back of the head. So that's the occipitalis muscle that's moving. Okay. Now, if we move on to Sanjiao 19, it no longer includes the branch to occipitalis. So we only move the ear. So this is what it looks like. Okay, and then if we move on to, let's say, the anterior muscle, anterior nerve, the anterior, actually, I forgot to mention, the literature is not clear as to how the superior auricular muscle is innervated. Some sources say that it's coming from the temporal branch in the front. Some sources say it's coming from the posterior auricular branch on the rear. So so based on what we know so far, it's very likely that that's an individual variation. Some people have one or other, and some people may even have both nerves innervating that muscle. So this is why when you see this video, even though it looks like we're stimulating the anterior muscle, rather than moving forward, if you look closely, there's actually a little bit of elevation of the ear. So some of that nerve is then feeding into the branch of the superior auricular muscle, causing an elevation. It's a subtle one, so I just show it to you. Again, not super exciting from a clinical perspective, but super exciting from a nerdy perspective that acupuncture points are this specific, that no branch is left unassigned. Okay, this is the reason why there's the acupuncture points. It is a map for the peripheral nervous system, period. So this is a summary of what I've just been talking to you about. What are the points, what are the branches, and what are the muscles they innervate? So if you want to become good at treating Bell's palsy, you need to first screen these patients to see which branches are working. So I'd like you to follow along with me. This is my standard sort of talk that I have patients to copy me. So I tell them, I want you to raise your eyebrows. That targets the temporalis branch. I want you to close your eyes tight. That targets the zygomatic branch. I want you to show me your teeth. That's the buccal branch. But there's two of them, two tests for the buccal branch. You also need a puff of air in your cheeks. Okay, inability to tighten the corners with the buccinator muscles causes fluid to leak out, and actually causes fluid to get trapped between your teeth and your cheek. We kind of take that muscle for granted. If you didn't have that muscle, food is always going to be stuck between your teeth and your cheek. We are actually always subconsciously pushing food back into the center of our mouth, so it doesn't go, get stuck in the sides. Marginal mandibular branch, I have them do pouting, stick out the lower lip. That will engage the marginal mandibular branch. And the cervical branch, as I mentioned, innervates the patellar muscle. That one I actually don't really test for two reasons. A lot of people don't know how to pop out the veins, okay? And also, it's not a muscle that's very useful in daily facial expression. So it's not a muscle that people are going to complain about. Before I explain my treatment strategy for how to affect these branches to treat Bell's palsy, we need to understand a little bit about how the face is controlled or command in the cortex of the brain, because there are situations where you might be asking yourself, is this person having a stroke or is this person just having a Bell's palsy? Obviously, stroke requires you to call 911. It just happened the night before. They could be having another stroke any minute. So you need to be able to differentiate this. And so this is why understanding this aspect of the cortical anatomy is important. So I'm sure most of you know that there's a homunculus representation of the brain, and where the trunk and the legs and the genitals are closer to the midline, whereas the arm and the hands are more sort of medial location, and finally the face is the most lateral location. Okay, so this is this means that our brain has dedicated areas that controls facial muscles, or muscles of mastication as well. This picture here gives us an appreciation of the difference between what happens when you have a lesion at the level of the cortex versus when you have a lesion at the level of the cranial nerve, or specifically the facial nerve. Cranial nerves I actually consider peripheral nerves. They're actually not, even though they come from the brain, the proper nomenclature is that they're considered all 12 cranial nerves are actually considered peripheral nerves. So that's why on the top of the slide here, we distinguish between whether the problem is a peripheral problem or is a cortical problem, okay? So let's just take a look at the diagram on the left first. First, I want you to appreciate that motor area of the face, okay, exists on both hemispheres. Obviously, left side of the hemisphere controls the right side of the face, and vice versa. And should you have a lesion in the cortex, that's called an upper motor neuron lesion, that's represented by this black edge over here, then that's going to affect impulses that your brain is firing that will arrive on the contralateral side. But notice that there is contribution from the opposite side of the brain that also arrives on the same side. So in other words, the face is kind of the exception when it comes to this decussation idea of right side controlling left. The upper part of the face, the forehead part, okay, will receive innervation not just from this side over here, the light blue one, okay, so the light blue one comes over here, but there's also branches on the opposite side that will affect the light blue on the top. However, if you have lesions at this level, where it's no longer in the brain, it's at the peripheral nervous system level, then it would affect both the blue and the green. So then you will have total loss of control over the upper face and the lower face. So that's the difference between a central or cortical or stroke-like type of paralysis versus a regular Bell's palsy, or if you prefer in Chinese medicine standpoint, a stroke would be more a Zhangfu level stroke, whereas Bell's palsy is more of a channel level stroke. And in other words, in a stroke, but that's from the central or cortical, the upper part of the face is spared, so it is still functional. This is why if you look at this diagram carefully, on this side there's no wrinkle, but on this side you still see preservation wrinkle because it's still able to raise the eyebrow. And that is your quick little test. If somebody comes in, they have paralysis of the face, they're of the middle age, they might meet the demographic of somebody who has a stroke, most likely not like a young person, of course, right? You ask them, can you raise your eyebrows, okay? And then go through all the tests I just mentioned. If they cannot do the stuff below the eyebrow, but they can raise their eyebrow, okay, then you know, this could be a stroke. Call 911. So this is just a pictorial explanation. I don't know if I kind of blundered through that, didn't explain it very eloquently. This picture here gives you a more clear understanding. Bell's palsy here is unable to move top and bottom, where stroke is only unable to move the bottom. Okay, so I'm going to show a video here of a patient of mine. This patient is actually a stroke patient, and he's being coached to move different parts of his face. I want you to see that he is able to raise his eyebrows, close his eyes, right? Okay, but he's able to raise his eyebrow, and you can tell the wrinkles are even. Okay, so this person, his facial problems. Okay, see how there's a drooping down here. To continue watching, he's trying to show his teeth, right? But he cannot pull the corner up here, right? But he has wrinkles on this side, so he can raise the eyebrow. A central facial asymmetry or cortical or stroke type of problem. He's puffing the cheeks, right? Yeah, but will preserve the ability to raise the eyebrow. So that's something really important to keep in mind. And that actually has ramification in our strategy too. Knowing that the brain, cortex of the brain, actually crosses over for the upper part of the face. Okay, so let's get on to some of the strategies now. Okay, so it wouldn't be a complete Chinese medicine lecture if we don't talk about something from the classics. I'm sharing with you passages coming from chapter 13 of the Ling Shu. The chapter 13 of the Ling Shu is entitled Channel Sinew, is actually the sole chapter in all the Chinese material medical text that talks about Chinese medical text that talks about the pathway of the channel sinew, or sometimes known as the tendon muscular channels. And each of these paragraphs on each of these 12 channel sinews finishes with the pathology. And so in the foot yang ming, or what we call the stomach channel sinew, there's interesting descriptions that matches Bell's palsy. I quote, corners of the mouth become weird, spasmodic, eyes cannot close. Based on these symptoms, we can actually confidently say that it's actually the zygomatic branch that's responsible for not able to close the eyes, and it's the buccal branch that makes the mouth look weird. Right? So for whatever it's worth, this might be the world's most earliest record of Bell's palsy. It's actually in chapter 13 in the channel sinew chapter, actually. And so these are just examples of somebody who cannot close their eyes. We've censored the eyes so you cannot see the identity. But you can see the mouth definitely is asymmetrical. So this is in ancient times, they would call that strange or weird or awkward. So what are the symptoms of Bell's palsy? Facial droop we just mentioned. You can have drooling problems because you cannot keep the corners of your mouth intact. You can actually have pain. One of the main symptoms people talk about is pain behind the ear. And that's actually where the nerve emerges. It's actually where pain is at central 17, basically. But sometimes you get pain around the jaw. I want to be clear that facial nerve is a pure motor nerve. So therefore, it does not have sensorial component, and therefore it should not cause pain. Trigeminal nerve is mostly sensorial, with the exception of the muscle mastication from V3. But usually when you have facial pain, it's trigeminal nerve. So why would facial nerve cause pain? In the beginning, it wouldn't. But as the saying goes, if you don't use it, you lose it. If you have asymmetry and those muscles atrophy and shrink and tighten, you can have pain from that constricture. But new, fresh Bell's palsy shouldn't cause pain, except for the spot that might be inflamed due to a possible inflammatory agent. A lot of times they think it's due to some kind of virus that causes that irritation. You can actually have increased sensitivity to sound. You can actually have loss of taste, and you can have changes in the way you salivate and you tear. These are not the most impressive symptoms that patients are going to complain to you about when it comes to Bell's palsy, but these are important to think about because I'm going to share with you some very interesting successes I've had by treating the facial nerve and to bring about improvement in salivation and actually a problem with hearing and tinnitus. So you need to assess all the branches as mentioned, raise the eyebrow for the temporal, close the eyes for the zygomatic, show the teeth for buccal, puff the cheek for buccal, stick out your lips for the marginal mandibular, and then pop the veins for cervical. And you take a video of your patient doing this so that after 2 or 3 sessions, you can reassess to see the improvements are there. Okay. So what is the strategy? The strategy involves connecting a muscle to its relevant branch. So I just mentioned, for example, to raise the eyebrows frontalis muscle, and that's the temporal branch. So you would put a needle in the frontalis muscle and a needle in Tai Yang and connect the two. So it's a nerve to its corresponding muscle. You can also, even more powerfully, connect the roots. So not the root, the trunks. So we saw about Sanjiao 17 and Qianzhen, those are trunks. If you stimulate those, it's more powerful, and you can connect those trunks to the individual branches. But don't do all the branches, only the branches based on what you found was not functioning in your quick little screen. Once you've done that, you connect, you confirm previously with the point-of-care device that you really are getting those activations, so that needle is perfectly placed to actually affect the patient dysfunction. Then you switch your alligator clip stimulators using only 1 hertz for only 10 minutes, maximum 15 minutes. Okay? And that's your treatment. It takes a lot of time to be precise to actually put in these needles and confirm them. So, but the actual treatment time itself is not very long. And you would do this ideally twice a week over 5 weeks. So that's 10 sessions. That is before a chronic case. If this is actually that's very acute, very new, then recommend if possible to treat actually every day for 2 weeks. So you're basically getting 10, assuming you work Monday to Friday, you're getting 10 sessions in 2 weeks every day. Okay. Now, what about some distal points? I like to say, it ain't Chinese style acupuncture if you don't have distal points, right? So as you know, LI4 is the command point of the face. That's the Chinese medicine explanation to why you do that. But there is a neuroanatomical and neurological explanation. It's related to the homunculus. If you allow me to go back a few slides, you'll remember that the thumb is mapped right beside the face. And therefore, by stimulating LI4, you are having a command on the face because it is an adjacent part of the homunculus. That's pretty amazing, right? Some of these things are working because of a direct homunculus effect, not because it's through radial nerve up into the brachial plexus, into C5 and T1. It's not that way, okay? It's because the thumb and the hands are so strongly represented, obviously the face as well in our homunculus, that they're adjacent to each other. So I will do LI4 bilaterally. And then we will need to do scalp acupuncture as well in the corresponding facial motor line. But you do it bilaterally for the reason I just explained, that when you have a stroke, the other side can still allow you to raise your eyebrows. So normally when you do scalp acupuncture, you just do the contralateral side, but face is the exception. You will do bilaterally for that. Okay, this is all based on actual neuroanatomy. So let me give you a quick case presentation. This patient I saw more than 10 years ago. This is a 32-year-old male patient who presented Bell's palsy. And at the time it happened, it was in late March. And then he complained about having pain behind the ear. And then the night before, and the next morning he woke up, there was asymmetry of the face. And so the patient went to see the GP 2 days later, and when the GP then referred them to a neurologist. Not much the neurologist can do, aside from prescribing maybe anti-inflammatories, or if it's suspected to be viral infection, maybe can prescribe some antivirals. What's interesting is that, what's not surprising is that this case happened 1 week after the patient has had an upper respiratory tract infection. So that's probably caught a virus, and the virus then went on to affect the facial nerve. And so you see this kind of stuff quite often. I always ask, have you had any recent infections, and so on and so forth. So by the time they came to see me, it was already about 10 days later, and on April 9th, and the patient, based on my quick assessment, cannot lift their eyebrow, cannot puff the cheek, cannot grin to show the teeth, cannot close the eyes. So that tells me right away which branches are involved. Cannot raise the eyebrow means it's the temporal branch, cannot puff the cheek, cannot grin, that's the buccal branch, cannot close the eyes is the zygomatic branch. There's no trigeminal nerve involvement because there's no pain, but you shouldn't always assume that. Viruses don't care whether you're cranial nerve 5 or cranial nerve 7. Sometimes, rarely, when you're unlucky, you will get both lesions in trigeminal nerve and facial nerve. So this is why you need to check. Even better, you should take a cotton Q-tip and stroke both sides of the face and compare sensitivity or lack thereof. So you know if you're dealing with just an easy case of Bell's palsy or a complex case of trigeminal neuralgia plus Bell's palsy. Patient having dry eye because of inability to close their eyes, so they start to use over-the-counter eye drops. So there are measures of improvement beyond symmetry. In the early stages, patient may not be able to move their face just yet, but if their eyes are not as dry, if they're able to sleep better because they're able to close their eyes a little bit better, because your eyes are open, you cannot sleep well, those are indirect measures that things are working, and you need to acknowledge this and inform your patient about this, because that's important for them to adhere to the program, so that they can then actually get to the stage where the improvement of the activation is there. So the patient has allowed me to photograph his face, but I needed to censor his eyes. But what I want to show you is the difference in the level of the eyebrow. So at the initial assessment, you can see on the patient's right side or our left, this inability to raise the eyebrow. Over treatment 4 starts to increase, over treatment 11 tries to be almost parallel. Here you can see the eyes cannot close. Here is closing, but not very tight, and then ultimately becomes tighter. Here, the corner lip cannot lift up. 4th treatment starts to get a little better, and then by the 11th treatment, it's almost level. Okay, so this is the ideal response you hope to achieve. Okay. Now, I want to give you a couple of clinical pearls. How to manage tearing or dry eyes in patients with Bell's palsy. In the early stages, when the eyes cannot close at all, eyes get very dry. As the ability to close the eyes improve, it's a little bit paradoxical. You might actually start having tearing eyes. And why is that? That is because we actually require the orbicularis oculi muscle to close to act as a windshield wiper to brush the tears from the lacrimal gland that secretes the tears into the nasolacrimal ducts that collects the tearing. So if you don't have that windshield wiping closure, then you can have tearing eyes, and that leads to double vision. So they cannot dry. I have a patient who's a watchmaker, they wear loupes and lenses, cannot do their job because you got this double vision because of clearing of the eyes. So your job as a practitioner is to improve the activation of the zygomatic branch that innervates the orbicularis oculi muscle, and that is how you're going to be able to treat both the dry and the teary eyes. Okay? Now, let's take this to a higher level. If you look at the orbicularis oculi muscle, it is actually dually innervated. It's innervated not just by the zygomatic branch, it's also innervated from the temporal branch on top. Okay, so it's not enough that they be able to close their eyes. They must be able to raise their eyebrows as well. Raising the eyebrow means the frontalis muscle is working through the temporal branch, and that means that nerve is working on the upper part of the orbicularis oculi muscle. And then you're going to be able to get full wiping. Otherwise, there's still going to be a little bit of tearing. So you don't have to go into that much detail with your patients, but you might be, this is important to know, the eyes are closing, how come you still have tearing, right? It's because they may not have the raising ability yet. You know in your heart that you need to get that temporal branch back, then they'll be able to have no tearing problems. Okay, so you need to target Taiyang, that's the branch, that's the point for the temporal branch. You needle into the frontalis muscle itself, connect those two together, and you stimulate. Now I want to finish by sharing you some very exciting applications of the facial nerve beyond just Bell's palsy. You can apply this for dry mouth, you can apply this with tinnitus, and also for cosmetic acupuncture. So I have a patient very recently who is a patient who had radiation therapy. And by the time he saw me, it was already a year ago, he had the radiation therapy for throat cancer. And that has left him, also he had chemotherapy as well. So I left him with the chemotherapy-induced peripheral neuropathy of hands and feet. That is beyond the scope of our lecture on facial nerve. Those things can be treated effectively using understanding the nervous system that I explained and the electrical stimulation confirmation technique that I talked about. We have ways to confirm the points affecting different branches of the nerves, the hands and feet, electrically stimulate it and restore that pretty consistently. The results are 8 or 9 or 10. And but what I was a little bit more timid or not confident about is, can I bring this person's dry mouth back? Because the source of radiation was actually over the region of the mandibular angle. And this is where Sanjal 17 or that nerve emerges. And of course, it could be just kind of local damage to the tissue affecting the salivary glands. But the patient also complained about loss of sense of taste as a result of this chemo and radiation therapy. And that's when a light bulb went off and gave me an idea. Because I recognized that the anterior two-thirds of the tongue, which is responsible for the taste of the anterior two-thirds of the tongue, is actually facial nerve as well. And the facial nerve is also responsible for supplying parasympathetic fibers to some of the most important salivary glands. So there you can tie two different symptoms back to the same origin or back to the same nerve. So using this technique of facial nerve stimulation, Sanjal 17, I knew there's a possibility I might be able to improve salivation. Okay, so this just kind of explains some of the sense of taste information of the tongue. This is showing you the anterior two-thirds of the tongue is innervated by, you can trace this back to cranial nerve 7, whereas the posterior one-third of the tongue traces back to actually cranial nerve 10. Okay, so this is what I mean by the facial nerve can affect not just the salivation, but also affect the taste of the tongue, and how I knew that this is actually a facial nerve issue. So this is the kind of complex picture, but I want you to just focus on the anterior two-thirds of the tongue, how I showed there's a branch here, and there's two salivary glands, sublingual, submandibular glands. These are all can be traced back to the facial nerve, okay? And this little circle here, it's called a stylomastoid foramen. This is actually where Sanjal 17 is located. So we are not really able to directly get here, but by putting needle in this region and applying electricity, some electricity would hopefully get back upstream and then affect these branches to affect salivation and taste of the tongue. Okay? And now notice there's another salivary gland here that is not colored in red. That's actually the parotid gland. And the parotid gland does not receive nerves from the facial nerve. It's actually only the submandibular and the sublingual. But fortunately, those two branches, those two glands are actually responsible for the majority of the salivation. 75% of the salivation comes from sublingual and submandibular. Even though parotid gland is the largest, it actually doesn't do a lot, okay, to improve salivation. So good news for us that we can stimulate the facial nerve to affect the glands that are actually doing the most salivation. So so I applied needling into Sanjal 17. I used the pointer plus to stimulate for 1 second, and I did 10 repetitions. And 10 minutes later, came back, kept the needle in there, and stimulated again. I told this patient, I can definitely help you. Your chemotherapy, peripheral neuropathy, I have a lot of experience with that. I may or may not be able to do the facial nerve, but we'll know after. I may or may not be able to help the salivation, but we'll know very quickly whether it's going to work or not. And so after 2 visits, the patient came back and said to me, hey, my salivation is better. And he says, you know how I know? Because every time I have lunch, I always have pasta. It's very dry. I always got to drink water to help me swallow. And I actually realized that I forgot my water bottle and I was still able to eat my pasta. So I was like, yes, okay. So we have so far done 7 or 8 treatments so far. He hasn't completed all 10 yet, but there's been stepwise, consistent, steady improvement. And he says he no longer carries water bottle everywhere. First time he came to my clinic for initial consultation, these people try out to carry the water bottle with them all the time. You can kind of predict what they're here for if you know what they came in with the water bottle. They're like attached, like an umbilical cord attached to their water bottle. But he says that I don't carry around with it anymore because it's not bothering him anymore. Now I want to finish up by talking about tinnitus because I know this is something that a lot of people ask acupuncture whether they can treat or not. And this was kind of an accidental discovery. When I was teaching how to stimulate the facial nerve trunk from Sanjal 17 to treat Bell's palsy and that kind of stuff, one of the patients in the class who had 15 years of tinnitus just went away immediately. So how can we explain this? First, we need to understand about the anatomy of the inner ear. So what you're seeing here are the 3 different bones of the inner ear: malleus, incus, and stapes. So they connect the eardrum to the cochlea So transferring the vibration into a wave, okay, or a vibration in the air into vibration in liquid inside the cochlea, which then receptors in the ear pick up a sound, okay? So these little bones don't move on their own. Bones have muscles that move them, and muscles don't move on their own. Muscles have nerves that talk to it to contract. It happens that the nerve that innervates the muscle to the stapes, called the stapedius muscle, is also innervated by the facial nerve. And this is likely the reason why, by stimulating the facial nerve trunk, some electricity went up that trunk to affect the branches that will ultimately arrive at the stapedius muscle to affect the stapes bone. So what does the stapes muscle do? This is just kind of summarizing that the stapes muscle. So here's the three bones, the malleolus, incus, and stapes. This little muscle here, stapedius muscle, is innervated cranial nerve 7, okay? So what this muscle does is that it reduces excessive oscillation of the stapes bone. And so in other words, it dampens the sound. Imagine you go to a loud concert, right? You get too close to a speaker, or you're at a construction site, there's kind of explosion goes off. You leave that location for many hours, or sometimes a couple of days later, you still have a boom, boom, boom kind of buzzing sound in your ear. That's because your body knows to preserve itself and tries to reduce the sound that's going to come into your cochlea by changing the tension of the muscle that controls that bone. So reduce the transmission, the conduction to it. But it takes them a bit of time to realize that, hey, the source of dangerous acoustic trauma is not there anymore. It's safe for me to turn that off now. This is why you still have it for a couple of days. But if that was to continue, this is phenomenon called stapedius myoclonus. And patients can actually hear clicking, buzzing, whooshing, gushing sound. An interesting thing is that these patients oftentimes also have spasms in other areas like TNJ muscles too. And later on, you'll see a picture. I show you some trigger point diagrams of muscles mastication, and they actually refer pain to the ear as well, to the inner ear. So there's actually some relationship with some of the muscles mastication and so kind of general tension, including tension in the stapedius muscle. So this is a very interesting new finding that it's only been about a year, actually. Last October, when I taught in New York, when we made this discovery, and I've been really milking everything ever since, trying to get people to do this to see if it works, try to do it myself on anybody that has tinnitus. So this is what I'm talking about. If you look at trigger point muscles in the SCM muscle, it refers pain to the ear. Muscles of mastication like masseter, it can refer pain to the ear. Pterygoids refer pain to the ear region as well. Because you can see medial pterygoid actually innervates, not innervates, but like radiates into the ear, right? So these muscles oftentimes are tight, spasmodic together with stapedius muscles, and therefore releasing these muscles could help. Earlier on, before I made the discovery, I would only reluctantly accept patient for tinnitus if I have palpated trigger points in these muscles. And some of them have worked, some of them have not. But now I just take everybody that has tinnitus using this technique. And I want to show you what kind of results I'm getting. Okay. So that student a year ago who got immediate relief of the tinnitus after 50, who's had it for 15 years, the result lasted one full day. Next day, some tinnitus came back, but it's only 40% according to him. And that result sustained for more than 1 year. It's been the next October now. So very interesting from just basically one treatment alone. Sometimes after COVID, you can, as you know, you can lose sense of taste, sense of smell, but some people get tinnitus after too, and most of them go away. Sometimes, if they get it bilaterally, only one side will go away. So I've seen patients that come in for like post-COVID tinnitus, one-sided. And so this could be anywhere from 3 to 6 months with no improvement. If these patients have trigger points in the muscles, mastication, SCM, as I mentioned, we have to go deactivate those. And in conjunction with Sanjo 17 directly stimulation, over 6 sessions, the patient says the tinnitus is no longer noticeable. We have a case where the patient gets immediate 50% reduction of tinnitus right away on the spot, okay? But it only lasts for 2 days, unfortunately. But every time he comes back, we do it, it works away right away. So something about that person's nervous system is not ready to let go of that myoclonus. But the fact that you can have this reproducible, consistent result is very, very encouraging, and definitely means that you should give it a try. I have another patient here, actually had a 2-year history of tinnitus and hearing loss. And by the time he came to see me, the tinnitus had actually dissipated. So, but because the patient also complained of facial muscle twitching problems, facial tension or twitching eyelids and things like that, I thought, what the heck, nothing to lose. He clearly has problems with facial muscles. I'm going to try the Sanjiao 17 to help the facial muscles, right? I don't expect to help with the hearing problems. But she's seen an audiologist that has told her that she definitely has hearing loss at a certain high frequency range, but she also has hearing loss in capturing speech-related sounds. So in one of those vestibules where they do your test hearing, they can play different sounds to see whether you can not just hear sound in general or just specific language sounds or speech sound. So they told her that she had problems capturing speech sound. And I treated her. She was actually somebody who came to a workshop that I was attending. And I treated her. And then it was a workshop required a headphone because we're listening to a translator. And so she could only put it on the ear that actually works. But she said that after treatment, she was able to switch that earphone into the other ear that previously had difficulty recognizing speech sound, and she was able to follow the speech from that. So let's stop and think about this for a minute. No way in a million years could it have possibly affect speech centers of the brain. I'm talking about like Wernicke centers or like Broca centers of the brain. It's not expected to do that. So how then did I affect the speech comprehension? I think that she might still have a little bit of tinnitus, and that tinnitus is preventing her from grasping speech-related sounds. By dampening the tinnitus, she now became better able, her brain became better able to grasp those sounds, okay? But she also thinks that her hearing may have slightly improved, which I don't know how to explain because hearing is supposed to be ocular cranial nerve 8. But treating Sanjiao 17 or cranial nerve 7 is not supposed to help that. But who knows? There's a lot of times these cranial nerves, their nucleuses are adjacent to each other, so maybe there's some kind of interaction. I want to finish with an application for cosmetic acupuncture. Okay, so you can use some of these points I mentioned earlier using Taiyang, which affects the forehead, small intestine 18, which affects the upper lips and cheeks, stomach 5, which affects the lower lips, and that's going to help you improve facial muscle tone. Okay, if there's weaknesses in that muscle, you're going to have asymmetrical facial expression, so you can actually improve symmetry. Okay, so what you would do, you would needle it the way I've shown you in the previous videos, confirm the point of applause that you really are acting those branches, because it's not going to work if you're just going to poke and pray, I say. You don't actually confirm they're actually doing what they're supposed to be doing, that is activating specific branches. And then you hook on the Eastern devices, the alligator clips at only 1 hertz. It's okay to cross the midline, so you kind of tie on together, small intestine together, stomach 5 together, and you just do that for 10 minutes. So at the end of the session, at the end of the acupuncture session, you would just do this and send them on their way. Okay, so I hope that gives you a new appreciation, a new lens to look at acupuncture points, and gives you some new ideas on how to treat facial nerve problem beyond just Bell's palsy. There are so many things that the facial nerve is able to do, from salivation to even tinnitus. And I am just amazed how accurate acupuncture points are. They're here for this very specific purpose to target very detailed branches of the peripheral nervous system. And so this is, hopefully I can, you can appreciate why this is so exciting for me, because it tells me that it's okay to learn neuroanatomy. Because if the more neuroanatomy I learn, had I not known the anterior 2/3 of the tongue is also facial nerve and also innervates the salivary glands, I would not know that I already have the skills to help this person. So hopefully that makes you feel that it's okay to kind of study both East and West, because at the end of the day, they're really one the same. Thank you very much. And if you want to learn more, here are some places you can find out more courses I offer, both online and in person. And I'll be happy to take any questions.
All right, great, thank you. Before we start the Q&A session, I just want to, on behalf of the group, I just want to thank you for your time, your knowledge, your generosity in sharing with the group, and we appreciate that. Not just for the good work that, not just only for tonight, but also the good work you're doing for the profession. Okay, thank you very much.
Thank you very much.
Yeah, we can do it. Yeah, you're still online. Okay, so this is about 8 o'clock right now. So if we're going to stay on a little bit to answer any of the Q&A session. So if you have any questions, please raise your hand and Dr. Chiang will call on you.
Okay. Okay, let me see if I read the questions or, yeah, here it is. Thank you. Just lots of thank yous. I don't see any questions at the moment.
I have a question, if that's okay.
Yeah.
I was just wondering if the needling and the e-stim on Sanjil 17 could also help patients with Sjogren's syndrome.
Yeah, certainly worth a try. So I have not applied to a Sjogren case, but I have one coming. So that's already
Excellent.
Yeah, so facial nerve 7, cranial nerve 7 is involved in the parasympathetic innervation of tearing and salivation. So it's, you know, if something like radiation therapy, which seems like a one-way thing, no way you can kind of make it come back, is able to improve. I think, you know, I'm not going to say cure, but I think there's a good chance there'll be some improvement. Yeah.
And you would apply the same method of e-stim, like the pointer plus?
With trying to affect the parasympathetic, like salivation, that kind of stuff, it's really just one needle in the Sanjil 17. You know, you got to confirm you got facial activation. So I explain to the patient why I'm trying to move their face. It's the only way I can confirm that I've actually successfully stimulated this branch, this nerve, which would then affect the branches that affect salivation. So I pull out the picture that I kind of show you guys to have a general idea. Otherwise, they're wondering, like, you know, why are you needling my neck? Why are you making my face move? Okay, you gotta explain that. But the treatment is actually just a repetition of the pointer plus. One Mississippi, 2 Mississippi. I do it for 10 times. Take a break for 10 minutes and do another 10 times, and that's it, really. And but you got to make it look like you're doing a lot more, so that the pain might they're not just paying for one needle, you know, right?
Thank you. Yeah, this is really great. I really appreciate it.
Okay,
I have a question.
I'm just, go ahead. I'm just reading some of the other questions. Okay.
What do you think about a patient who's had Bell's palsy for 10 years? Like severe chronic case, he was initially treated, but it wasn't helpful. So he stopped all treatments altogether.
Yeah.
So half of his face is still paralyzed.
Okay, so the challenge with that is actually the constriction that has happened. Okay, so because it haven't used the muscle around, there's atrophy and constriction. So that would limit the improvement that you're seeing. So there's a need to actually needle the muscle directly to help relax them, plus activation of the nerve supply to them. Just because they have done acupuncture before, does not mean they have done acupuncture in a way that specifically stimulated those motor branches of the facial nerve. Most treatments for Bell's palsy, both East and West, are needling the muscles. So they're actually stimulating the trigeminal nerve. But the trigeminal nerve is known to have very fine communication branches with the facial nerve. So facial nerve and trigeminal nerve are like an endless seamless web. So most standard approaches is actually using the trigeminal, or using the sensory, or using the yin to affect the facial or the motor or the yang. It's using from the yin to a yang approach. The approach I'm teaching you is to directly go to the yang or motor branches by stimulating the facial nerve trunks and branches. So if the goal is to activate the facial nerve, why beat around the bush? Just go straight to the facial nerve. And so even though they may have had acupuncture, chances are they did not have this style of targeted nerve trunk stimulation acupuncture. So I wouldn't rule it out. And the more you work with patient neurological problems, time actually is irrelevant. I have lots of examples of patients who have problems, 15 years of tinnitus, right? Is 15 years of tinnitus more difficult than treat somebody who's had a year? No. If the nervous system is actually very plastic, the more we know about it is that's actually the norm, not the exception. So don't let that shake your confidence. Always say, I can help, okay?
Thank you.
I noticed a question about Ramsay-Hunt. So Ramsay-Hunt is a syndrome that's both cranial nerve 7 and cranial nerve 8, which can result in some deafness. So this will only be expected to improve the facial nerve 7 or cranial nerve 7 portion. It's not expected to help the deafness that can be associated with the Ramsay-Hunt. Other questions are for Easton 1 hertz and intensity tolerance. Yes, it's usually 1 hertz for the face. Intensity is usually about a 3 dial. I want them to basically to feel it. It's not more or better, but I do want them to be aware. It's possible you can see movement, but they don't feel it. It's important that they can feel it. Okay. Can you please review the angle of Sanjo 17 for your treatment? Yeah. So unfortunately, because of the nature of this presentation, it's not a practical course, we cannot show you how to actually done. The best advice I can give you is use the needle tube. Don't rush the needle. Use the needle tube first to find where the mastoid and the jawbone meets. And so you want to find the best deep valley you can get into. So that tube will tell you the angle. That's going to be a little bit different from everybody. Okay, and then you need to insert about it could actually going to be like 1 cun. Okay, because a lot of people have a lot of adipose tissue in the neck area. So 1 cun seems deep, but you got to imagine you passing through some adipose tissue in order to get to that depth. So it's not, so you, in other words, if you use a 1 cun needle, one and a half cun needle, it won't be enough. You really should be doing this technique with a 2-inch needle. So you're not running out of needle. Okay. Is there a timeline for the release of the Fundamental Chinese Acupuncture book? Well, originally, if I had it my way, I would have been done by now. It'd be submitted this year, but you know, there's always competing priorities. So I'm hoping that I can finish it next year, so that it'll be out by 2024. But don't hold me to that. The needle length I already explained. Pointer pulse, did you say 10 hertz for 1 second? Yeah, the pointer pulse device, the basic model is preset at 10 hertz. You cannot change that. So it's just the factory setting. The more higher end models allows you to switch between 1 to 16 hertz. So some people find 10 hertz a little bit too strong. You could do, I would say like 5 hertz, but I would not recommend doing any lower than that. Okay, so I think I've exhausted the questions that's in the chat box. Are there any other questions live?
Okay. Fantastic. And Tony, do you have an email that they can reach you, or what's the best way?
Yeah, so in the first slide, I gave you a bunch of social media addresses, so you can use the chat functions from those social media to contact me.
Okay, great.
Yeah.
Great. And if you missed this, we'll on our email to the attendees, we'll recapture this information again.
Yeah.
Okay, I guess that concludes tonight. Thank you very much for attending, and be sure to check out the upcoming functions. Okay, all right, good night, everyone.
Thank you. It's been a pleasure. Thank you. Thanks again, Tom.
Okay, thank you.
Okay, take care. Bye.